are again here. We are again here with the Dr. Tushar Shah scientific series at the Federation of Family Physician Association of the India. Now, Dr. Tushar Shah is very well known to all of us after two great series. And in the line today, now this is a monsoon season. So it is a very practical topic today. And today's topic is monsoon fever. Now, I don't know about the other part of the country, but in our Gujarat, Baroda city, we are already starting patient of fever since last 4 to 5 days. And our OPD is really flooded with the fevers. Daily we are getting 70 to 80 patients in the OPD with the fevers. So with that, I request, I think Dr. Jason Darbar sir is not there. So I directly request Dr. Tushar Shah sir to start his session. Dr. Tushar Shah sir, please.
Hi, thank you so much for calling me.
I will introduce and welcome him, Dr. Pragnesh.
Yeah, please, madam.
Yeah. Good afternoon, everyone. Good afternoon, Dr. Tushar and Pragnesh Shah, the president. And Dr. Tushar Shah doesn't need any introduction. He is a passionate teacher and general practitioner in Mumbai, very well known to all of us. He has had 2 series with us. He has finished his MD internal medicine from Nair Hospital, and he is a renowned practitioner at Advanced Multi-Speciality Hospital. His teaching passion is that from morning till night, anytime, he is ready with answers. He is with us all the time. And with the devastating effects of monsoon all over our country, this is the ideal topic today. He is going to touch upon monsoon fevers. All over India, all over the world, there is devastating effects of the monsoons, and it's going to be started fevers. So over to Dr. Tushar Shah to enlighten us about monsoon fevers.
Thank you, Dr. Preeti. Thank you so much for the introduction. What fever should we cover and put in the bracket of monsoon fevers is something that I've been debating about. We all know that mosquito-borne illnesses are considered monsoon fevers, but we also are seeing today, as of the last few weeks.
Hello, sir.
Hanji.
Sir, possible હોય તો તમારો ફોન horizontal કરી દો.
Okay. Sound કેવો છે?
Sound sir perfect.
Sound okay.
Wait a minute. Is this better? Is this better?
Yes, sir. Yes, sir.
Yes, better now.
So mosquito-borne illnesses are, of course, considered monsoon fevers: malaria, chikungunya, dengue, and the lesser known, lesser seen filariasis. But we are all seeing in our OPDs currently respiratory tract infections more than we are seeing, say, dengue or malaria. So I would say the change of weather does cause more respiratory tract infection also. Also, monsoon fevers should include acute diarrheal illnesses that we are all seeing currently again, possibly because of contamination of sewage water with drinking water. So similarly, enteric fever should be considered also a monsoon fever. So there are so many infections that we are faced with whenever monsoon occurs. Leptospirosis is one such infection. So let me, now this is a huge topic, obviously, and also it is slightly embarrassing to talk about this because most of you are better than me in your volume of work related to monsoon fevers. So I'll touch upon areas which are slightly less commonly talked about and therefore may be more interesting to you. Otherwise, this is a very dull topic. So let us begin with malaria. Within malaria, we know that Vivax malaria is the topic of importance for the outpatient physician, and you know everything about the dosing of malaria. A couple of things that I think we might want to revise. One area is primaquine utility in Vivax malaria. We all know that primaquine is required to completely eradicate When do you give Primaquine and how do you give Primaquine? After the patient's fever has been taken care of by chloroquine or by ACT, you have to give Primaquine to prevent the relapse. And the chief difference in giving Primaquine after ACT and after chloroquine should be that after chloroquine, you can wait for 1 week before you, before you start Primaquine. Because the chloroquine is a long-lasting drug, and relapses won't occur for at least 1 week or more. So after you have finished the course of chloroquine, after a patient starts taking food properly, you can start Primaquine. थोड़ा सा पानी देंगे मैं. You can start Primaquine after a week also. However, if the patient has taken ACT, you must remember that ACT has a shorter duration of action, and you can get a relapse of Primaquine in about relapse of Vivax in about 2 or 3 days after stopping ACT. So you must start Primaquine as soon as possible in a patient who has received artemisinin combination therapy. So what I do is, if I get a patient who has what looks like malaria, I'll send the blood for rapid malarial antigen, for example, and I ask the lab to keep some extra blood so that if there is malaria, I'll ask them to run a G6PD qualitative on the same patient. If qualitative G6PD shows that there is partial deficiency, I will ask for a quantitative G6PD and decide the dose of Primaquine. So you must start Primaquine as soon as possible. So second problem with Primaquine is this, that Primaquine is a weight-determined dose medicine. So you must take care that you give the correct dose. We are used to giving 15 milligrams of Primaquine once a day for 14 days, which is 0.25 microgram per kg body weight, and we presume 60 kg body weight, and therefore give 15 milligrams. However, there are patients who are 80 kg, 90 kg body weight. So do calculate it as per body weight at 0.25 and therefore give the correct dose. Also, remember this, that if the patient's Primaquine has been given and patient still gets a relapse, then you may have to give a second dose of Primaquine after curing the relapse at a double the dose, meaning instead of giving 0.25 microgram per kg, you will give 0.5 microgram per kg, which might become 30 milligrams per day. So the correct use of Primaquine by the day and by the dose is important. Another thing that that comes to mind when you think of preventing relapse is if you get Vivax malaria in a pregnant female, you treat it with chloroquine or ACT. Now ACT is considered safe in the sense that it has greater benefit than risk even in the first trimester. So if you give ACT or chloroquine, and you have to prevent a relapse in pregnancy, because you should prevent a relapse, otherwise severe anemia can occur in pregnancy. You can't give Primaquine because Primaquine is teratogenic and it is contraindicated in pregnancy. So such patients, you will give weekly chloroquine double strength as a prophylaxis till the patient delivers, and thereafter you will have to, after the patient delivers, you have to do the G6PD of the baby and the mother if the baby is lactating, and then Primaquine has to be given to the mother. So that is the general use of Primaquine in Vivax malaria. What happens when there is Primaquine usage required in a patient who's G6PD deficient? If you do a qualitative test, you see that the diet decolorization time is greater than 60 minutes. You do a quantitative test and you see that there is deficiency of G6PD. Though the G6PD is detectable, but it is deficient. Then your dose will change. You know that you have to give 45 milligram or 0.75 milligram per kg body weight correctly per week, once a week dose for 8 weeks. So 8 weeks, 0.75 microgram per kg per day, per week. So this dose is the preventive dose in a patient who is G6PD deficient. Another area is, should G6PD be tested in women? As we know, G6PD deficiency is a X-linked recessive disease, and therefore is less common in women. But you must check G6PD in women too, because it is not rare to have GCQB deficiency in women. So that is about Primaquine use in Vivax malaria. The other area within malaria which might be interesting to you is prophylaxis of malaria in travelers. There are two situations here. If you, as an Indian citizen, are going to travel to, say, Africa, you will have to take prophylaxis if you are going to sub-Saharan countries of Africa. Sub-Saharan means if you go to Egypt or Morocco or Algeria, you don't need prophylaxis. But below the Sahara Desert, if you go to, say, Kenya, Tanzania, or South Africa, you will need to take prophylaxis. And here you must remember that the prophylaxis is for falciparum malaria because that is a more prevalent malaria in that continent. So now from here, if you're traveling there, you have to take mefloquine as your drug of choice. Mefloquine is, we started 2 weeks prior to travel and taken 250 milligram once a month for an adult who is 60 kg or more. There are other doses for children, which dose-based charts are available. So standard dose for adult 250 milligram once a week. If you're going to Africa, start 2 weeks prior, continue through the travel, and continue for 4 weeks after return from that continent. Mefloquine, of course, is contraindicated in people who have psychiatric disturbances or seizure disorders. And in that case, we have trouble because the other drug that is commonly indicated is called Malorone, which is a combination of atovaquone and proguanil, which is not available here. So we may have a problem. And patients who can't take mefloquine, what you can do is ask them to carry with them an ACT course and use it when fever occurs empirically without waiting to prove that this is malaria. Generally also, and whenever a patient travels to African countries, I tell them to please carry your Lumarax or RT plus CD or what you have, meaning an ACT course, which should be ACT. Chloroquine they need not carry because it's useless in falciparum. They should carry an ACT course, artemisinin combination therapy course, and and use it whenever fever occurs. Should they carry Primaquine? Do you need Primaquine in a patient who gets falciparum malaria? Yes, a single dose of Primaquine is recommended in every patient who gets falciparum malaria to decrease transmission because Primaquine kills gametocytes, which are the reproductive forms of malarial parasite. So Primaquine, the dose previously recommended used to be 45 milligram single dose. The currently recommended dose is 15 milligram single dose of Primaquine in a falciparum patient. Luckily, we don't get so many falciparums within India, much less common than Vivax. So this is about travels from India by Indian citizens to foreign countries. Now we come to travels of our relatives or people who come in from abroad here during monsoons especially. If you have a relative who comes from the UK or from the US, they will often get what is called as Malorone, a daily tablet of atovaquone plus proguanil as prophylaxis. They can get it from there. They can also get mefloquine, but remember, we don't need to cover falciparum if they are coming to India. We need to cover Vivax, and mefloquine is a slightly more toxic drug. So what you should give if people are coming from abroad here is ideally chloroquine. That is Lariago DS or a double strength tablet of chloroquine. You have to give once a week. You start 1 week prior, continue here, and continue for 4 weeks after departure. However, if often they do not get chloroquine abroad, so there are two things that can be done. One is always ask your relatives whenever they come here to carry with them back chloroquine for the next time they come, and ACT, that is Lumarax or RT CD like drug, if they get fever there after reaching. So the preventive for them would be, of course, chloroquine. What if they don't get chloroquine? They land here, and you are told, okay, we have landed. We have not taken malarial prophylaxis, and this is monsoon. We want to take prophylaxis. What do you do for a traveler who's come from US or UK and landed here? This is what I do. I start doxycycline as soon as they land. The reason is doxycycline has a quick onset of action, is a good prophylactic drug for malaria, and I start them on Lariago DS simultaneously. So the very first day, they'll start with doxycycline to be taken daily, just 100 milligram per day in an adult. Remember, you can't give doxy below the age of 9 or in possibly pregnant women. We give 100 milligram per day, continue it through the stay, and for 4 weeks after leaving the country. That is if you give only doxycycline. But what I do is I start doxycycline, give it only for 8 days, and simultaneously start Lariago DS. Lariago DS, that is chloroquine DS, I will start on day 1, give the next dose after 1 week, that is day 8. After that day 8, I will stop the doxycycline. Doxycycline has now done its work. Chloroquine has started acting as a preventive, and then I continue chloroquine, double strength once a week till 4 weeks after departure. This is what I do. Use doxycycline for the first week only, first 8 days maybe. So this is for people who have come unprepared and have landed without taking prophylaxis. Yeah, so this is about chloroquine prophylaxis. So I repeat, always tell your relatives if you love them, especially if you don't love them, don't tell them. But if you love them, tell them to carry with them ACT and chloroquine whenever they leave the country, so that they can use it the next time they come, or if they get fever there. Okay, so that is about malaria. I don't want to discuss a lot of other things in malaria, simply because you know most of the things in malaria. These are 2 areas that I thought were important, but I can take them in Q&A, whatever queries that you may have. So that is malaria. Then we come to dengue. My favorite way to teach dengue is to tell you about what mistakes not to make. First, do no harm. First, do no harm is the principal guidance of dengue. And again, those who have heard me before, they've heard this repeatedly. So I'm sorry that I'm repeating some of the things. But first of all, do no harm by avoiding antibiotics. A patient of dengue is easy to recognize clinically. Patient comes with high-grade fever on the first day, and the fever is associated with, as you know, bone-breaking pain and retroorbital pain. It's not difficult to diagnose the classic presentation of dengue. Of course, dengue can come with variations. Sometimes dengue can even be subclinical, as you know. So dengue can come with lower grade fever, with lesser body ache, lesser or no orbital pain. But if you do suspect dengue, meaning any fever during the monsoons, which is without cough, cold, which is the main localizing symptom of respiratory infection, we have to think of dengue malaria first, and maybe enteric next. So if the fever is high grade, you think of dengue with bone breaking fever, and you will do your tests, which are, as you know, our first 2 tests for dengue are almost always CBC and NS1 antigen, and you will diagnose dengue. The first rule is therefore not to over investigate. Don't do CRP, for example. You do your CBC, dengue NS1, and maybe malarial parasite, and once your dengue NS1 is positive, the second do no harm principle is antibiotics. We often tend to start antibiotics on day 1. My request to you is start investigating on day 1. Every fever which is not accompanied by cough and cold must be investigated on day 1. I'll repeat this because this is important. Every fever which is not accompanied by cough and cold must be investigated on day 1. Do your basic CBC dengue or CBC malaria or CBC dengue and malaria on day 1. Do not wait. We tend to tell the patient, okay, आपको बुखार है, body ache है, कोई viral fever होगा, ये दवाई देते हैं. And often in that दवाई देने में, we will give doxycycline or azithromycin, which are completely useless and harmful, of course, harmful because they will cause side effects. So we tried to investigate on day 1. You may get an excuse that, okay, this patient not affording. How do I give an expensive investigation? My request to you is tell the lab to charge less. We don't often enough tell the lab to charge less. And if you tell them to charge less, they will have an arrangement with the lab to start charging less for in this season, especially in this season for dengue, etc. Also, you must realize the patient. You know what is the principle of autonomy in ethics, right? Autonomy is let the patient also decide. You can't decide for them how much money they can spend or not spend. Ask the patient, भाई ये डेंगू का टेस्ट है 800 रुपए का टेस्ट है कंसेशन में 600 रुपए का हो जाएगा जानना जरूरी है मेरे लिए कि आपको कैसी दवाई देना क्या मैं ये टेस्ट कर सकता हूँ तो इफ द पेशेंट सेज ऑफ कोर्स करिए डॉक्टर साहब यू विल बी सरप्राइज्ड हाउ मेनी टाइम्स द पेशेंट विल से आपने बताया क्यों नहीं टेस्ट है तो आपने किया क्यों नहीं टेस्ट इवन इफ दे आर पुअर पेशेंट्स आर daily wage earners and they want to get better. They want to know the diagnosis. They want to apply for leave if they are at jobs. So they should know the diagnosis. Okay, so that is uh, about investigating on day one itself. If you don't investigate, you are doing harm. If you give antibiotics, you're doing harm. You give paracetamol. NSAIDs are another thing that can harm the patients in dengue. We do not want to harm them. We can't treat dengue with any specific drugs, but we can harm them in many ways. So NSAIDs, I usually try to avoid NSAIDs. But if the body ache is kind of just terrible for the patient, I for the first 3 days or maximum 4 days, I sometimes use 1 or 2 doses of NSAIDs. Meaning I'll give one injection Moveran on day 1 or day 2 till the platelet counts haven't fallen, and or I will give one ibuprofen tablet maybe once or twice and restrict them as much as possible, but only for first 3 days or so. The reason is beyond the 4 days, when the antibiotics come into play, the IgM antibiotics start appearing in the blood. After that, dengue can cause complications in the form of capillary leak, and NSAIDs are not good thing to give in a patient who has now developed a capillary leak. So I would give, and also of course the platelet count starts falling more and more after day 3. So definitely do not give NSAIDs after that. But in the first 2 or 3 days, just to reduce the misery of the patient, you may give NSAIDs. So this is one more way we can harm the patient by giving excessive non-steroidal anti-inflammatory drugs. So we have one way to not harm, and that is not give antibiotics. One way not harm, not give NSAIDs. Antibiotics are given freely in dengue. Dengue, I would say in monsoon, the commonest indication of dengue has become, common indication of antibiotics have become unfortunately, dengue. Dengue does not require any antibiotics. Do not think that you can prevent secondary infection in dengue, and don't make that as an excuse for giving antibiotics. There is no such thing as secondary infection in dengue. And even if there is a secondary infection going to occur, you cannot prevent it by giving preventive antibiotics. No such thing as preventive antibiotics in this situation, in viral fevers. So yeah, so that is the second way not to harm. The third way not to harm is to ask for hospitalization too early. First 4 days will require hospitalization only if the patient is vomiting and completely dehydrated. After 4 days, the commonest reason why people are wrongly hospitalized is a fall in platelet count. Don't be scared of fall in platelet count if the patient is getting clinically better, meaning if the fever is coming down and yet the patient is getting a low platelet count, don't worry. So, you know what will happen? You know how the platelet count behaves, right? The platelet count continues to fall till the fever is there, maybe up to 7 days, which is the usual duration of fever. And then the platelet count will fall further for another day or two after the fever goes away. Now, so what will happen is patient on the 7th day is doing well, eating well, no fever or minimal fever, but the platelet count is 20,000. You get panicky, and 20,000 obviously to the patient looks very bad, and you will admit the patient. But remember this, in an afebrile or patients whose fever has gone away, dengue patient, do not be scared of low platelet counts. Whereas in a highly febrile dengue patient, if the platelet count is even 70,000 on the 3rd day or 4th day, please admit such a patient, because this not to give platelets, but these patients will have severe dengue in other forms, meaning typically capillary leak. So that is one thing that we should not do. Don't admit in the fag end of the fever because you want to, you're scared of platelet count or you want to give platelets. Another mistake that is made, and we should prevent it as family physicians, we can prevent it, is platelet transfusion given in hospitals. Many hospitals keep the cutoff as 20,000, 30,000. You should not give platelets up to 5,000 if there is no wet bleeding. Wet bleeding means blood which is lost in hematuria or hematochezia, that is stools, nose, gums. Dry bleeding in the form of petechiae is not important. Wet bleeding is important. So if there is no wet bleeding, wait, let it go below 10,000 and then consider transfusion. That helps you as a GP control. You will, of course, if you can, talk to the consultant daily. Once the patient is admitted, talk to the consultant on a daily basis. If the patient is very close to you, your relative, or if you just want to save the patient from harm, please visit the patient daily. I'll tell you one more reason why you should visit a patient daily. And don't allow wrong things to happen to the patient in the form of platelet transfusion. Also, when the platelets go low, one of the commonest drugs given is parenteral steroids. Please do not allow that. Do not yourself give steroids because the platelets have fallen now. Steep fall from 1,50,000 to 75,000 in one day, and you become panicky and you want to give steroids. Don't do that. Platelets will come back. Steroids are harmful, again, not to be given for low platelet count. Very rare cases in severe dengue when there's very high ferritin level and sometimes the patient is in ARDS, etc. Steroids are given in the ICU, but otherwise, most cases, even with the very bad dengue, do not require or do not deserve steroids. So that is about not to give platelets unnecessarily, not to give steroids for low platelets. Another thing that will harm the patient that you can prevent is recognize capillary leak early and avoid fluid overload in a patient. This is an important area where you can actually save a patient's life. Around the 5th day, when the antibodies appear, that is the IgM antibodies appear in dengue, in some patients, especially the younger patients, capillary leak starts, meaning patients will extravasate their plasma into various tissues. And this can be lungs causing ARDS, pleural space causing pleural effusion, peritoneal space causing ascites, gallbladder area causing pericholecystic collection, edema of the face, hands, feet. If there is such a leakage, capillary leak, the patient can land up with severe complications. And now this condition can be prevented also. Some people will get it irrespective of what you do, but some people will get it because of you, meaning because of the treating physician. Some patients get capillary leak, which is very bad. So what happens is on the 5th day or so, when the capillary leak starts, often the hemoglobin rises, the PCV rises. That is one of the indicators of capillary leak. 20% rise in hemoglobin or hematocrit is considered a evidence of capillary leak. Fall in albumin is considered evidence of capillary leak. When that happens, we chase the hemoconcentration by giving excessive IV fluids, which are isotonic fluids, meaning we give saline, glucose, etc. And we say, okay, there is hemoconcentration, let us pour in fluid, 2 liters in 6 hours, whatever. Now, this worsens the capillary leak by increasing the hydrostatic pressure within the blood vessels. What we have to give is fluids, if at all we have to give fluids, which have high oncotic value, meaning they should be hypertonic and they will retain the fluid in the intravascular space rather than cause leakage. So, how will you, as a family physician who does not do hospital management, manage this? One request is take care that the IV fluids given on day 2, day 3, day 4 are not continued on day 5. Day 5 is the crucial day. If you can see the orders of the patient, or you can ask the relatives to tell you, send you on WhatsApp the photograph of the treatment sheet. And if you see that the patient was given 4 pints in the first, second, third day, and the same 4 pints are being CT-oiled, CT-oil is continuous under the same treatment, then you can talk to the consultant and say, okay, this patient, his or her hemoglobin is rising, and I can see that 4 liters or 2 liters of normal saline or 5% dextrose are going. Can we switch to some hypertonic solution like Hemaxel or 20% albumin? And hopefully the consultant will realize that Okay, this mistake should not be made. Otherwise, what will happen is when you give isotonic fluids or hypotonic fluids to a patient who has already started a leak, capillary leak, you will push them into what is called ARDS. It's actually pulmonary edema. And this pulmonary edema can be disastrous because we will often lose the patient because of that. So that is something which is part of not doing harm that you can help the patient with. Yeah, so this is about dengue. We have done now a little bit about malaria, a little bit about dengue. Let us do something about acute gastroenteritis. uh, we are seeing a lot of acute gastroenteritis currently, right? And we know that it is due to contamination of sewage water in food, street food, for example. Vessels or utensils are washed in dirty water, and sometimes contamination of sewage pipelines occurs uh, with regular drinking water pipelines. So we often get diarrhea. Now, what kind of diarrhea is this? Uh, Many times such diarrheas are viral diarrheas, not necessarily bacterial or amoebic diarrhea. So two or three messages here. Again, something which is important for not harming the patient. If the patient presents with vomiting and loose motion simultaneously, or vomiting first, followed by loose motions, with fever, think of non-bacterial, non-amoebic non-amoebic infection, meaning non-antibiotic gastroenteritis. I call it non-antibiotic gastroenteritis. There are many gastroenteritis which are infective but do not need antibiotics. So this is one such infection. And even some E. coli infections do not require antibiotics. So remember this, that if a patient comes with acute presentation of what we call food poisoning or gastroenteritis, then most of them do not require antibiotics. We just treat them symptomatically, even if they have fever. Uh, Wait for 2 days, at least wait for 2 days, hold the antibiotic and see how they respond. My commonest prescription for acute gastroenteritis is famotidine 40 milligram OD or BD for acidity, domperidone or whichever antiemetic you like, ondansetron, domperidone, whichever you like, orally 3 times a day maybe, and a probiotic, say Saccharomyces boulardii, that is Econom kind of probiotic, twice a day for the diarrhea, and SOS cyclopam. I tell the patient, have patience, 2 days, take paracetamol when you get fever, and if you don't get better in 48 hours, I will give an antibiotic. If you think the patient is toxic, just do a CBC. Occasionally, CBC will have a high WBC count because of dehydration. But even then, if you see the high WBC count, I would be okay with having an antibiotic started, but without a WBC count which is high, because often the high WBC count will be normal in acute gastroenteritis. Do not give antibiotics to the patient as far as possible. And if you do give some antibacterial or antibiotic, please do not give a combination of an imidazole and an antibiotic. Do not give Ornof, O2, Ciplox, TZ, Cifran, CT. Nonsense. Do not give this combination ever in your life. Meaning, if you want to give some both together because you are completely confused whether this is amoebic or bacillary, give both of them separately so that you give correct doses. But otherwise, don't use the combinations. Uh, as I said, first, you will not require antibiotics in most gastroenteritis. Second, if you do give antibiotics, try to give antibacterial drugs, not anti-amoebic drugs. Antibacterial acute presentation with cramps, fever, uh, loose motions is often bacterial. Salmonella, which is non-typhoidal salmonella, or Shigella, which is causing dysentery with blood in stool. They are they will need antibiotics, but most infections are bacterial if they are not viral or toxin mediated. And here, therefore, you should use only antibiotics, not anti-amoebics. If you use antibiotics, you have a range of antibiotics to offer, but do not use rifaximin. Do not use rifaximin for acute gastroenteritis with fever, because this is a drug reserved for mild infections. That also is an off-label use. Remember, it is an off-label use to use rifaximin in gastroenteritis, and also it is reserve the drug for uh, if you want to give for traveler's diarrhea, or if you want to give for patients with IBS or patients with what is called SIBO, small intestinal bacterial overgrowth, reserve this drug for that. Do not give for acute gastroenteritis. I prefer to use either doxycycline or a cefixime or a quinolone. Quinolones are considered drugs of choice if you want to give acute. And but we all know that salmonellosis, which is one of the causes of bacterial infection, salmonella have become increasingly resistant to quinolones. So I don't like them. I principally use a clavulanate combination with a cefixime if I want to give something a little more bactericidal than doxycycline. So this is about gastroenteritis. Of course, supportive therapy, I don't need to detail, and you know about that. The next infection that I would cover is respiratory tract infection. Is respiratory tract infection a monsoon illness? Well, it's a perennial illness. It's a uh, illness that stays throughout. But in India, influenza is more commonly seen in monsoon months than in typically as seen in the West in winter months. So we are again seeing some influenza, especially in adults. I'm catching a swab positive influenza currently. So here it is very important to recognize influenza because you have a specific drug or oseltamivir to treat the influenza. So how do you recognize influenza? Patient comes with fever, usually high grade fever, significant body ache, extreme malaise, cough, and cold. So fever, cough, cold, and body ache, malaise, these are the classic symptoms of influenza. Remember, nasal symptoms should be present to confidently diagnose influenza. If you have diagnosed influenza and you know that you are in the influenza season, you don't need on an OPD basis to confirm it by doing a swab. If the patient can afford, I do sometimes do the swab because I want to know what the current prevalence is. Otherwise, you don't need to do a swab to start oseltamivir. So if you have a patient who suspected influenza within 48 hours, very important, within 48 hours of onset of symptoms, please start oseltamivir, that is your fluvir or anti-flu. 75 milligram BD in adults, children's doses are different, and for 5 days. I always combine oseltamivir with something like domperidone omeprazole combination because oseltamivir or fluvir can cause significant nausea. So I am very keen to start the drug in patients who have risk factors, who are elderly, who have comorbidities, and in younger people if they are living with older people. So do start this. You can even give prophylactic dose. I always give prophylaxis to the senior citizens in the family. There are some people who believe that prophylaxis should be reserved, should not be given unless the patient is severely immunocompromised, and you should give oseltamivir only once fever starts. But what we are seeing is extremely infectious uh, uh, influenza, and it's very quick. And to have so many fairly disabled people within the house can be a burden to the household. So I do give prophylaxis, and the prophylaxis is 75 milligram OD in an adult, and the duration of prophylaxis is not specific because you'll have to continue giving prophylaxis till somebody or the other in the family has fever and cough. So that is how to recognize influenza, how to treat influenza. If you do want to do a swab of influenza, don't ask for that multiplex type of test, respiratory multiplex. Just ask for nasopharyngeal swab for influenza, where they will not give you the subtype of influenza like H3N2, H1N1, because that becomes a more expensive test. They'll just give you, yes, influenza A is positive or influenza B is positive. What we are seeing is a lot of influenza A, which we can presume is H3N2. So that is about upper respiratory tract infection. However, remember that you can get away without treating upper respiratory URTI due to influenza without oseltamivir in patients who are young and may not need any therapy. So that is about URTI. The other monsoon illness that we can talk about is leptospirosis. We do not, unfortunately, suspect leptospirosis, and therefore the most of the patients will either get better on their own or they will develop what is called as Weil's disease and go to the ICU. Luckily, leptospirosis is many of the times self-limiting, resolves on its own. However, an occasional patient will die. So how do we go about this? Can we prevent leptospirosis? Yes, one of the monsoon illnesses that can be actually prevented. So leptospirosis should be uh, prevented by giving doxycycline once a week during periods of heavy monsoon and heavy flooding to people who have to go to work on foot. So if you have your watchman, your maid in your building, uh, you can think of giving them or their family members doxycycline 200 milligram in adults once a week through the period when heavy monsoons are there. If you cannot do that, meaning you don't know how can I give doxycycline every week for 3 months, if you don't think you should do that, if you don't live in areas which are not very waterlogged, you can just give them a strip of doxycycline to keep at home and tell them that if they get fever without cough cold, then without meeting their doctor, they can start doxycycline twice a day if they are not going to be pregnant or if they're older than 9. Give them doxycycline 100 BD and tell them to take it for 7 days if fever appears. That is how you can prevent serious problems. How can you recognize? The more important thing is recognizing leptospirosis. We can recognize dengue easily. We can recognize malaria easily. We don't recognize leptospirosis so easily. It's a difficult diagnosis to make. But early in the disease, if a person comes with fever, without cough, cold, with significant malaise, weakness, body ache, and ocular pain, we do think of dengue first because ocular pain is a symptom also of dengue. But remember, ocular pain can occur even in leptospirosis. So if the patient has ocular pain, significant body ache, fever, and no cough cold, think of leptospirosis early in the disease. If you miss that, because what will often happen is leptospirosis is a biphasic illness. This kind of viral picture will come. Leptospirosis is not a virus, but if this kind of viral picture will come for the first 3 days, and then the patient will have a lull meaning a break in the fever, and then the second phase will start after a couple of days of break in the fever. Now, the second phase is the phase which can get complicated into what is called as Weil's disease, where the liver, the lung, and the kidneys are affected. Here, so therefore, what you have to do is, if the patient comes with a history of fever today, do ask them, was there no fever for 2 days, and was there fever prior to that? Go retrospective, and if they give you a biphasic history, your antenna are up. This is a red flag, and you will send the blood for. What do you send the blood for? You will send the blood for the RT-PCR related to leptospirosis, and therefore, and you don't do leptospira IgM early in the disease. If the patient comes to you in this second phase, the way to clinically sometimes make out that this might be leptospirosis is look for tenderness of muscles. Significant tenderness of calf, thigh, or flank muscles can be present in leptospirosis. Of course, severe leptospirosis, when it becomes Weil's, patient will have jaundice, patient will have cough, hemoptysis, and other complications, other features of the complication. But by that time, it may be too late. As you know, late in the disease, antibiotics also do not work as well as they work early in the disease. So, yeah, recognize it early and start antibiotics. And in a patient who has come with a biphasic fever, I would be very tempted to keep the patient in the hospital rather than keep the patient at home. So that is leptospirosis. Then we have chikungunya. Chikungunya is we have time, right? Okay. Chikungunya is a disease which is very clinically very apparent. There's absolutely no difficulty in usually diagnosing or at least suspecting chikungunya. Important to remember is patient will have fever for 2 days and then maybe some rash. What is important and interesting clinically in chikungunya is patient presents to you in say the month of September with arthritis, polyarthritis, asymmetric polyarthritis. This is the time, and this is for 6 weeks, for example. This is the time you have to ask the patient, did you have fever at the onset of arthritis? Did you have a mild rash at the onset of arthritis? If they say yes, then you are probably a little relieved, because then this polyarthritis, which has been going on for several weeks, may have a self-limiting nature, meaning that chikungunya, more than 70% of patients recover completely from arthritis within 3 months. So if you think that they have arthritis right now, jog their memory and ask them for fever few months back. That might give you an idea as to how to approach this arthritis, because unless several months or maybe an year or so have passed in arthritis of chikungunya, we do not give disease modifying drugs like methotrexate. Many rheumatologists give this drug, methotrexate, in chikungunya arthritis, knowing well that this is chikungunya. However, there is not much evidence, and there is an excuse to give DMARDs by saying that, okay, chikungunya may unmask previous rheumatoid arthritis. Now, this unmasking business does not go down well with me, because most of the chikungunya patients are not of the phenotype profile for rheumatoid arthritis. So I would say, okay, don't stretch it too far. Wait. Many patients will have a resolution, which is maybe after a few months, and see. But at the same time, having said that, there is some recommendation without any RCT, that you may give DMARDs in uh, chronic arthritis chikungunya. The mistake made by us in chikungunya is that we give too much NSAIDs, because the patient is miserable, obviously. But don't give too many NSAIDs for too long. We give steroids when we become desperate. Again, something that you can hold your hands and try to give as little as possible. Uh, uh, Having said that, I do know that chikungunya patients are miserable. They have difficulty even going to the washroom from their bed. Yeah, so that is chikungunya. Then we have lastly filariasis. I'll take it very quickly. I'll take 2 minutes on filariasis. Filariasis is a monsoon illness, because filariasis is also caused by mosquitoes, and right, mosquitoes of what variety? I don't know. Many varieties of mosquitoes cause filariasis, not just one, like Aedes aegypti in dengue or chikungunya, or Aedes albopictus also in these two. But in chikungunya, in filaria, more than one variety can cause. Now, in filariasis, what is important to know is that there are two forms of presentation to the family physician. One form is acute, first episode of filariasis. The first episode of filariasis is proximal, meaning in the pelvic area, in the vaginal area, or in the scrotal area. Is the presentation of filariasis first time. Patient can present with fever and hydrocele, for example. Whereas the commoner presentation that we get, the first time filariasis is often missed. Patient has fever, chills, the filarial worms, the filarial larvae are injected by the mosquito, and the patient does not even recognize, because the fever was short lasting. And then the filaria larvae grow inside us. And when they start blocking the lymphatics is when our main symptoms start. So the second way of presentation of filariasis is the chronic variety, where the patient has already had lymphedema, and now the patient comes with acute fever and rigors. Remember this. Acute fever and rigors in a patient with filarial lymphedema, or elephantiasis as they call it, is not due to filariasis. It is due to secondary infection in the limb. Now, this secondary infection should be treated with antibiotics. Our tendency is to give hetrazane or diethylcarbamazepine, diethylcarbamazepine, DEC, and that is a wrong tendency. In a patient with established old filarial limb, any fever with cellulitis-like picture on the limb is secondary bacterial infection and not a filarial aggravation. Such patients are typically given doxycycline, and sometimes this doxycycline given for 4 weeks or more. So this is how we treat any exacerbation of filariasis, filarial limb inflammation. Yeah, so I'll finish here. I don't know whether we have time to take questions, Dr. Preeti, but we can. You can unmute yourself, Dr. Preeti. Okay, somebody's asked, what is the role of doxycycline in P. vivax infection? I don't know, Dr. Preeti, I can't hear you. I'm not sure whether you are muted or not.
Hello.
Yeah, now we can. Please.
Yeah. So there are a few questions on YouTube. How do you diagnose H1N1 clinically? I think you have covered part of it.
I'll repeat it very quickly. H1N1, we can't diagnose the subtype H1N1, but in influenza can be diagnosed by presence of four symptoms. Cough, cold, cough meaning cough, dry cough, and sometimes sore throat. Cold meaning rhinitis or nose block. Fever, which is high grade to begin with, and systemic or constitutional symptoms in the form of body ache or profound weakness. If you have all four in a patient in this season, you should think of influenza and nothing else.
Yes, sir. What is the role of hydroxychloroquine in chikungunya?
Hydroxychloroquine is a disease-modifying drug used by some people as a drug in chronic chikungunya arthritis. However, very clearly, very important to know that if you have to use a DMARD in chikungunya arthritis, you have to use methotrexate and you do not use HCQ. So HCQ is completely out. Even methotrexate has poor evidence, but you can use methotrexate if the chikungunya goes beyond 3 months. Yeah.
So there's another question. Filariasis, is it unilateral or bilateral? I think it can be either ways.
Either it can be unilateral, and if the patient is unlucky, it can be bilateral. And it doesn't need two mosquitoes, just one mosquito is enough.
Yeah. How to differentiate differential diagnosis between dengue and leptospira clinically?
So yeah, there are some overlaps. As you know, high fever occurs in both, orbital pain occurs in both, body ache, weakness occurs in both. So they may appear the same. A couple of things that I think I will be helped of. One, history of wading in water. You must ask history of exposure to waterlogged areas. And in dengue, you must ask family history of fever. Dengue mosquitoes are very chanchal mosquitoes. Chanchal matlab they flit from one body to another body very fast. So if there are more than one person within the family, the dengue mosquito can easily infect multiple people within the family by just going from one place to another very quickly. So Leptospirosis does not behave like this. Leptospirosis does not have a family history of multiple members falling ill. So this is one important area. And of course, as I said, leptospirosis has a biphasic nature. Even dengue biphasic has been described, but leptospirosis is much more commonly a biphasic fever. So you can have 3 days of systemic illness followed by a lull and then a more severe illness. Yeah.
So there's a question on hematocrit in dengue, and I think you have covered that. And that's all the questions in YouTube. I have a question, sir. When in any of the viral illnesses or any of the monsoon fevers, when do the panic button start, or we do the LFT and the renal function tests? We go for higher investigations. At what stage? Because dengue does affect the liver or the kidney sometimes. So your opinion on that, sir?
Great question. Red flags and when do we kind of become more invasive in our investigations? So any patient who's, of course, after 4 days of dengue has entered the 5th day, I would investigate both the renal and the liver function very quickly. 5th day of fever of dengue, which is when a patient who's toxic, we have to look for SGOT-PT. The reason why we look at SGOT-PT, that is the transaminases, is that high SGOT, high SGPT, like 400 SGOT and 250 SGPT, will tell us that this is a severe form of dengue. Also, high enzyme level also occurs because of ischemic hepatitis, which is an overlay of dengue hepatitis, meaning patient is dehydrated and has a high enzyme level. So yes, I would do and renal profile, of course, which is the baseline because the patient may worsen, and renal profile will also give us the status of hydration. If the BUN to creatinine ratio is more than 20, then we will know that the patient is significantly dehydrated. So yeah, they'll be useful as soon as patient enters 5th day of fever and is looking sick. That is when I would do it. Yeah.
How do you approach a fever with chills? A patient with fever with chills?
So now we are going into the domain of non-monsoon illnesses also when we talk about fever with rigors. If a patient has fever with rigors, look for localizing symptoms first. If the patient has fever, rigors, severe headache and low backache, malaria. If patient has fever, rigors, generalized bone-breaking fever, dengue. If patient has fever, rigors, cough, maybe rusty sputum, pneumococcal pneumonia, or any other form of bacterial pneumonia. If the patient has fever, rigors, and flank pain, and some dysuria, pyelonephritis. Remember, cystitis does not cause fever rigors. Pyelonephritis causes fever rigors. In fact, the first etiology of fever and rigors in a diabetic patient, even in monsoons, should be pyelonephritis as your diagnostic process. So fever, rigor, pyelonephritis. Then uncommonly, fever, rigors in a diabetic patient, look for cellulitis in the legs. Fever, rigors in a patient who has, say, traveled and has come with some history of stool with mucus, look for amoebic liver abscess, because amoebic liver abscess is an important cause of fever with rigors. Yeah, so many causes of fever and rigors, and therefore the localizing symptom will become very important.
So there is one question from my side. In monsoon, we can see a fever without any system involvement. Only fever is persistent since for last for 3 days, 4 days. Lastly, we do investigation, and at that time, investigation also shows normal reports. Means count is normal, even little rise in SGPT, urine report is also normal. Still, there are no focus we find, and ultimately on 5th or 6th day, fever subsides. So we can't understand the exact etiology of fever, and with paracetamol only fever goes. So I think many of us have seen this type of fever.
Absolutely. So have I. So one important thing here, because you are talking about a very specific situation. If fever is without localizing symptoms, then besides malaria, dengue, which we test for, please test for typhoid. You must send blood for culture. How many times people ask, when do we send blood for culture for typhoid? And I always say, you must suspect typhoid on the second day of fever. If the fever has been low grade on the first and second day, if there are no cough, cold, dysuria, localizing symptoms, and if the patient has continuous all-day fever, low grade all-day fever in the first 2 days without localizing symptoms, think of typhoid, because as you know, it's a step ladder pattern. The fever will gradually go up, and the localizing symptoms like diarrhea, abdominal discomfort will happen only a few days after the onset. So the kind of fever that you are describing may be enteric fever, and we will not diagnose it because CBC will be often normal, enzymes will be often normal, malaria will be negative, dengue will be negative, urine will be normal, and we have not sent culture because we are not in the habit of sending culture, and therefore we will not diagnose. Can typhoid go away without any treatment after day 5? Like the case you described, it can. Body can take care of typhoid after 5 days of fever. Typhoid can be subclinical. Typhoid can be asymptomatic also. So there's a range of presentations of typhoid. So you can get typhoid which goes away. And you can have malaria which goes away without anti-malarials. So yeah, but as you said, even after sending blood for culture, we may not find typhoid, and we will be without a cause. And with fever without a cause is not uncommon, and it should not make you upset. It should only teach you patience, that you have to wait and watch unless red flag symptoms appear. Thank you, sir.
So there's a question come up from Dr. Nagbhushan, Bangalore. Chikungunya arthritis is anti-CCP positive and RA positive. I don't understand the question. Maybe he's talking of a specific
He's
situation.
asking, no, it's a question mark maybe. So chikungunya arthritis is not anti-CCP positive, CCP positive. If you get anti-CCP positivity in what looks like chikungunya, it is the rheumatoid arthritis. RA test is positive in about 5% of the whole population in the across the country. So RA positivity is non-specific, for example, and I would not be worried about that. So yeah, chikungunya. Yeah, that's about that.
Thank you, sir. A lot of comments appreciating your talk. Over to Dr.
Yes.
Sanjay Shah for the vote of thanks.
Yes. Yeah. Thank you, Dr. Tushar Bhai. You have given very good information regarding this monsoon fever, and we are approaching this season, and it will be definitely helpful in our practice. Thank you,
Thank you,
Dr. Pritibhan. Thank you, Dr. Pragnesh Bhai, and all those who have attended this CME. And thank you, Analyst Sport, for giving nice presentation. Thank you. And we again meet Dr. Tushar Shah next month. Thank you, Dr. Tushar Bhai.
Thank you so much, sir. Thank you. Bye-bye.
Thank you, sir. Thank you very much.
Thank you, Dr. Preeti. Thank you.